What is the real natural history of low back pain? It's surprising that often quoted statistics in healthcare are not necessarily qualified by source and quantified by firm statistics. Knowing where and how conclusions are arrived at can sometimes reveal that there is often a startling group effect of acceptance without investigation. This appears to be the case with our assumption about low back pain and its resolution. The often quoted statistic of 90 to 95% recovery for low back pain within 3 months of onset started with a 1966 study that never actually collected natural history data. In this study by Delane et al., 90% of patients had stopped consulting with their doctor within 3 months. When patients with low back pain did not return for follow-up, the researchers assumed that the patients had recovered. The literature, though, is ripe with studies and reviews that refute this assumption, yet few of us seem to be aware of the breadth and weight of these scientifically sound arguments against this statistic. Let's look at what is likely the real story based on past evidence, and then look at a current study that investigates what actually occurs with a natural history, even for those that are treated. Von Korff et al. In 1996 had shown that a significant number of even acute low back pain patients had persistent pain if followed for 1 to 2 years. 69% of patients with recent onset of low back pain and 82% of patients with non-recent onset of back pain were still experiencing back pain 1 year after the initial episode. In a primary care study by Stanton et al. In 2008, only 26% of patients with acute low back pain were pain-free at 6 weeks after onset. As much as 62% of low back pain sufferers will have 1 or more relapses during 1-year follow-up of an initial episode, and 40% still have low back pain at 6 months. Initial relapses tend to occur at 6 to 7 week intervals, with a decreasing number of cases suffering recurrent pain each time. While 95% of patients may have returned functionally, 31% continue to suffer pain with those activities. So what are the costs of these recurrences compared to the initial episodes? Wozniak et al. Published in Spine in 2006 that 84% of total medical costs for low back pain were related to recurrence. A recent study attempts to evaluate the natural history of low back pain by surveying patients in 4 different back pain care settings on 2 continents. The title of the publication is It Time to Rethink the Typical Course of Low Back Pain? By Donaldson et al., published in the Journal for the American Academy of Physical Medicine and Rehabilitation in 2012. They had 3 primary research questions. Are low back pain recurrences common? Do episodes worsen with multiple recurrences? And does pain change location in any recognizable pattern during an episode? The study was conducted at 30 locations across North America and Europe with 589 responders. Participants were given a single-page self-administered questionnaire at their initial visit to their provider. 4 types of clinics were included: primary care, physical therapy, chiropractic, and spinal surgery. No exclusion criteria were used, so there was no distinction based on type of low back pain, history of onset, or comorbidities. .3% were from primary care physicians, 67.4% were from physical therapy clinics, 18.7% from chiropractic clinics, and 6.6% from surgical care clinics. 83% had pain in the back and or buttock pain. 17% had leg pain only. 83% were working full or part-time, and 11% of the responders had undergone previous spinal surgery. Nearly 35% reported that their first episode lasted longer than 3 months. Now, in answer to the first research question regarding recurrence of low back pain, 73% of responders had at least 1 episode of recurrence. 54% had at least 10 recurrences, and over 19% had 50 or more recurrences. Those patients from physical therapy clinics had significantly higher frequencies of recurrence compared to the other clinic types. Now, regarding the next question about worsening on subsequent episodes, participants were asked to rate the recurrences using 5 domains. They were asked to compare the original episode versus the most recent episode of pain based on pain intensity, interference with leisure activities, interference with work activities, duration of episodes, and distal most extent of their pain. Regarding improvement, about 37% were better in total. 61% were worse in one domain, and 20.5% were worse in all domains, and only 8.6% were the same. For the research question, did the pain location change? Well, the pain location changed during the episode in 75.6% of patients. Of these, 63.2% reported that their pain first spread distally before retreating proximally during recovery. Now, there are some limitations. A survey was administered on the first visit, but we don't know who they had seen previously or if there was much change in pain from the most recent onset. Recall bias is of particular concern because patients were having to reflect back over, in some cases, years to remember their first episode and subsequent episodes. When trying to estimate recurrences, an episode was used, but was not clearly defined, so there may be variation in participants' interpretation of what an episode meant. The investigators were looking at chronicity, so they focused on past experience with low back pain, not the current episode. Because they were attempting to look at all low back pain, there was no distinction made regarding the underlying cause or diagnosis. Realize these are limitations, not necessarily weaknesses. That determination is based on whether the examiners accomplished what they wanted and how well they did that statistically. The researchers should be applauded because although not all questions about the history of low back pain can be answered, this study adds even more weight to the increasing literature support for the disbanding of the commonly taught and practiced assumption that low back pain is primarily short-lived. This clearly has huge impact on healthcare policy decisions, redefining low back pain as a chronic condition that for many individuals starts with the initial episode. Attempts at finding approaches to more intensive attention and management of factors that are modifiable and actionable by the doctor and patient must be discovered and implemented. That research has yet to be done.